investigate brain alterations in neuropsychiatric disorders. As our study's background, environmental conditions and access to resources can refer as a neighborhood advantages for children. And previous literature showed that children who grew up in a disadvantaged neighborhood showed decreased neurocognitive function, impaired neurodevelopment, and increased risk of psychiatric disorders. Even though current literature investigated neighborhood advantages effect of neurodevelopment, they mostly focus on the socioeconomic aspects of neighborhood and not comprehensively investigate other aspects of neighborhood like education and environment. So to investigate these literature gap, we hypothesized that increased neighborhood advantages are associated with enhanced neurocognitive development in children, and different aspects of neighborhood like education, environment, and socioeconomical could have a distinct effect of neurocognitive development. For investigating neighborhood advantages, we used an index called Child Opportunity Index. Can we click the video? Yeah. This index based on the children residential addresses zip code and investigates children access to resources using 29 different indicators. This gives us an overall neighborhood quality score as well as 3 domain-specific scores to investigate educational opportunities, indicators like early education center, socioeconomical domain, and such as poverty rates, employment rates, and environmental quality, using indicators like access to healthy food. This slide summarizes our methods. As you can see, we investigated over 6,000 children aged to 10 years old. We used a Child Opportunity Index as neighborhood advantages score. For statistical analysis, we used generalized additive models controlling for demographic and family factors and applied parameter optimization and cross-validation to ensure our analysis robustness. In addition to generalized additive model, we also used a mediation analysis to explain neighborhood effect of cognition, how much of the neighborhood effect of cognition can be explained by the brain pathway as known as white matter development. And for our outcome measures, for brain development, we associated 20 white matter association fiber tracts development. And for cognitive functions, we used NIH toolbox test and investigated different cognitive functions like language, memory, processing speed, and attention. This heat map summarizes our results in neighborhood effect of association tracts. Like I said, we investigated 20 different tracts and controlled for factors like age, sex, race, ethnicity, BMI, puberty. And after controlling various factors and using advanced statistical method like generalized additive model, we only found a specific tract called superior longitudinal fasciculus 1 is significantly associated with neighborhood factors. So our results show that increased neighborhood advantages are associated with increased development of SLF1 tract. And this association is more dominant in the left hemisphere. Overall neighborhood quality and social economic aspects of neighborhood showed association in both hemispheres, left and right, but education and environmental domains only showed association in the left hemisphere for this tract. This highlights the superior longitudinal fasciculus 1. This tract is a dorsolateral component of the SLF, links frontal, parietal, and temporal regions, and it functions in the memory, attention, and language processing. And this SLF tract impairments previously found that associated with ADHD, autism, psychosis, and various psychiatric disorders. And this heat map shows the association of the neighborhood advantages association with cognitive functions. As you can see, we found that various cognitive functions are associated with neighborhood quality and advantages. And increased neighborhood shows increased enhanced cognitive functions. And most dominant association is shown in the language development as well as composite cognitive scores like assessing IQ or knowledge-based cognition. And this is the summary, this heat map is summary of our mediation analysis, and it shows us that neighborhood effect of cognition partially explained by the SLF1 tract development, and this statistical analysis also highlights this specific tract development importance. As conclusion, our study highlights the important role of neighborhood advantages on cognitive function and white matter development. Neighborhood level and interventions like improving educational, environmental quality, or reducing socioeconomic disparities can foster children's neurocognitive development. And addressing neighborhood disparities may reduce psychiatric disorder risk and improving long-term health outcomes for children. As our study's limitation, we used a cross-sectional analysis for this study, and this, even we try to explain using mediation analysis, it still limits our causal interpretation. And even though child opportunity index is a comprehensive score assessing neighborhood factors, it still lacks time-based factors and household-specific details. So in future, longitudinal large data set using both household, neighborhood advantages, and including time-based changes could be beneficial to understanding environmental effect of neurodevelopment. Thank you so much. I would like to thank our lab mentors and especially my supervisor for this project, Dr. Süheyla Karayumak, and thank you for the Turkish Association for Psychopharmacology. If you have any question. Türkçe'de alabilirim soruları. Sonrasında böyle daha
The questions may be in Turkish or in English. Thank you very much. Is there simultaneous interpretation?
Scientists associated with this research, I'm going to thank you for our association, presenting this study in our meeting now. And also, I have some question about this findings. I guess these findings are some proof that we have already known some facts about social environment and the social advantages. And what do you think about this study have implications in clinical application, and what these findings promising for our future research?
Thank you. Yes, even though some literature investigated neighborhood and social environment effect of neurodevelopment, they mostly focused on the functional neurocognitive development. And the white matter studies has a very limited, and their sample sizes are small. In this study, we investigated over 6,000 healthy children, and they're in the early age of educational attendance. They're age 8 to 10 years old. So even in the early ages, the environmental has an effect of white matter development, and this area needs a large sample studies and longitudinal analysis, and we found a specific track significant across 20 long-range intrahemispheric association tracks. So it could be a potential neurodevelopmental pathway how neighborhood can affect cognitive function. And this is, in the future longitudinal studies, we hope that following this track development, and maybe in the adults showing the impairment of this specific track, could be beneficial to assess which children are in the higher risk to affected by the neighborhood conditions. And this index is analyzing 29 different indicators. And it shows us that even the smallest educational aspects of neighborhood or smallest thing around the neighborhood could have an effect on children, and changing that with the political interventions or social intervention is small things could matter in the child neurodevelopment. I believe this study highlights that.
Thank you.
Thank you.
Any other questions? Başka soru var mı arkadaşlar çalışma adı?
Any other questions? Thank you very much. Dr. Çağla Develi, the next presentation. Good morning, everyone. I am Dr. Çağla Develi from Marmara University, from the Pediatric and Adolescent Psychiatry. Today, I will be sharing the conclusions of our study where we evaluated the situation of the children and young who applied to our clinic. And in recent years, there is an increase in the emergency psychiatric applications for children and adolescents. And the reasons for this application include suicide attempts, depression, anxiety, behavioral crisis, and family crisis. However, the long waiting times at emergency service and insufficient bed capacity is a problem in our country and all over the world. Our purpose in this study is to evaluate the demographic data, clinical characteristics, and treatment processes of the patients, and how many of the patients referred for hospitalizations could be admitted. Our study was a retrospective study from October 1st, 2022 to 13th of September 2024. In total, there were 1,355 consultations, and 57 of them were decided for hospitalization. And our interviews were DSM-5 based, and SPSS was used for the analysis of the data. Out of the 57 patients, 36 were girls and 20 number boys. The median age was 18.5, respectively 19.9, and the psychiatric complaints were already ongoing for a while before their application to our clinic. And the girls generally were being followed up for psychiatry for 14 months for girls, and it was 7 months for boys. And the girls and boys were also undergoing formal education, and 41% of the girls and 57% of the boys had psychiatric disorder complaints previously. When we look at the distribution of the diagnosis, we generally saw depression disorder. And among the girls, depression was significantly higher compared to the boys. 69% of the boys and 33% of the girls were depressive. And comorbidities were also seen among the girls around 44%, and comorbidity was seen around 19% for the boys. And there was also an important increase in terms of suicide attempt rates. 80% of the girls had a suicidal attempt before their application, and the ratio was 42% for the boys. And for the boys, the distribution was homogeneous. For the girls, the higher medication use was around 91% among the ones who attempted suicide. And actually, they already were on psychiatric medication like atypical antibiotics or SSRIs and antipsychotics or SSRIs before they applied. The patients who were admitted, only 43% of the patients could be admitted to the pediatric clinics, and the remaining were referred to the adults clinics for admission, and some rejected admission. 12% of the patients were discharged after follow-up with outpatient clinic follow-up, which was through mutual negotiation and understanding. And in conclusion, we can say that psychiatric emergency admissions in children and adolescents are increasing. However, there's a limited capacity of beds. Therefore, some of these patients are followed at outpatient clinics or given medications. Suicidal attempts and depressive disorders are especially prevalent among the girls. These findings highlight the need for strategic planning to improve the inpatient capacity and service coordination. Thank you very much for your attention. Thank you very much. You informed us about the admission of children and adolescents at Marmara. Any questions? I have a question. In referring these patients, you emphasized the bed capacity. The ratio of the ones who rejected admission was low. What was the ratio? 31% rejected. The reason for rejecting admission and the method. The ones who rejected questioned the conditions of the service and they didn't accept the closed service idea. Generally, the parents reject. Although the parents want an admission sometimes, the children reject. And they sometimes do not want to wait in the emergency, and the waiting conditions in the ED are not appropriate, and as they have to wait for some time before admission, some reject because of this reason. Yes, this is a question mark in our country. There are also pediatric psychiatrists here. So in legal terms or in medical terms, what's the responsibility of the clinicians regarding the rejection of the patients? So about the cause of the rejection, do you have legal or medical responsibility? Yes, shortening the waiting periods or improving the service conditions may help. So is there a risk on the clinician? What shall the clinician do in such a case? Well, even if there's a rejection, we closely follow up the patients. Actually, they're not out of the system. Okay, then, if there's no other question, we can proceed with the next presentation. Thank you very much. Dr. Merve GÖREN. Hi, everyone. I will be talking about the catatonia in child and adolescent psychiatry. It's a rare disease. First, let's start with catatonia. It's a psychomotor syndrome. There are motor, behavioral, and autonomic signs. And in this, according to DSM-5, 3 out of the 12 signs must be seen, like supernegativism, catalepsy, mannerism, posturing, wax flexibility, echolalia, grimacing, and in the pathophysiology, GABA hypoactivity and glutamate hyperactivity are seen, and we use Bush-Francis catatonia rating scale, and generally we see this in mood disorders, psychotic disorders, autism spectrum disorders. And this is Bush-Francis catatonia scale. There are 23 articles, and the scores are O 1, 2, 3. O is absent, 1 is occasional, 2 is frequent, difficult to interrupt, and when there's 4 is severe. Epidemiology. The acute psychiatry in patients is seen among 9 to 17% of the adults. For the kids and adolescents, is seen less than 1%. It's although not statistically significant, it's seen more among the females. And in terms of diagnosis, there is a 30 to 50% of false positive cases. And there is not a prior psychiatric personal or family history of our first case, a 17-year-old female, and for the last 4 days, she was room-bound, minimal intake, and near total mutism. And she was evaluated as conversion disorder at an external center, and she was discharged. And then she came to our ED And at first, we actually thought she was converted. However, as this utopia continued, we diagnosed the girl with catatonia. We administered 10 milligrams of diazepam, and after that, she started to see the light, she said. And the BFCRS score was 14 at the baseline, and we admitted the girl to our ward, but due to the oral intake problems, we referred her to the intensive care because there were hypokalemia and metabolic alkalosis, and the vital signs were stable during the ICU during the 17-day stay, and there was an infection which was managed, and the medical exclusions were done, and escitalopram was initiated, which had a lower dopaminergic effect, and we increased the dose to 200 milligrams. And on the first day, we started clonazepam, half milligrams twice a day, and we also had an signed approval of the person, and we started lorazepam, which was family obtained and initiated with 3 milligrams per day. And upon the first dose, the patient briefly awoke and engaged with her surroundings. Although it was not meaningful improvement for us, it was benzodiazepine-resistant catatonia. So what was benzodiazepine-resistant catatonia? There are 3 catatonic signs. Lorazepam 8 milligrams per day was administered for 5 days. There is again a reduction in GABA, but there was glutamate dopamine dysregulation problems, and ACT was recommended. However, some refractory patients, for some, NMDA antagonists are also used. And for the pediatrics, with ACT, 80% of the children improve. And therefore, on the 7th day, we continued with ACT. And we started with 10%, and no lower range could be possible. On session 4, there was a meaningless seizure. Therefore, we planned 15% for the next session, and we increased the dose to 200%. And our complications were as follows. On session 7, we had to administer midazolam because there was a long seizure. And on session 4, there was an agitation table. Therefore, we started lorazepam, and we were continuing it for 3 days, and then we discontinued. And generally, we expect the efficacy within 24 to 72 hours. And during this time, we monitored sedation. And what was opening was that when she first opened her eyes, it was the 6th session, and there was perseverative writing. And after 7th session, she was uncooperative but clearly awake. And she was saying that I was well at 7th session, but I couldn't open my eyes. And she was trying to open her eyes, and she was smiling. And after the 8th session, she started to engage with the doctor and mother, but declined any peer contact. And after the 9th session, she was fully awake. She interacted with the peers. And after the 10th consultation, she wanted to discontinue the treatment. And the score improved from 14 to 6 after the 10th session, and within 2 weeks, actually, an improvement is awaited. And you can see the perseverative writings. And what was agitated catatonia? Motor behavioral and echophonomania are the 3 signs, clinical pages. Echophonomania are the tones of the echolalia and echopraxia. First, lorazepam stress test is administered, and if it's meaningful, we continue benzodiazepine. But if it's not improving, we start ACT urgently, and also the underlying causes should be excluded. Generally, it is confused with the psychosis and mania. manic depression. And what did we do when the mutism, posturing, or stupor lasts for longer than 24 hours? We need to suspect catatonia. You can use the catatonia scale for this. Lorazepam stress test is both a diagnosis and treatment, therefore it's important. After lorazepam challenge, within 5 or 10 minutes, there was a response, but in our patient, it was 30 minutes. If there is a positive response in the lorazepam test, we can increase it up to 8 milligrams. But when there is fever, autonomic instability, we need to proceed to ECT. But after 8, we started ECT on the 8th day because there was no fever or another instability. We administered ECT for 10 sessions with intervals of 3 or 2 days. And during this time, we monitored the clinical response. We also excluded the underlying reasons. And we need to be very careful at the intensive care, and we need to avoid antipsychotics because there is the risk of NMS. We started antipsychotic on the 10th day. However, for augmentation reasons, after the 10th ECT, we added antipsychotic. We need to inform the family, and after the treatment, we need to evaluate the patient again. These are my references. Thank you. Thank you very much, Dr. Merve. Although rarely seen, it's an important problem in pediatric psychiatry. We need to know how to manage it. Any questions? Thank you very much. Neuromodulation. In the medical psychiatry history, it's although it's not totally enlightened, we see that not only ECT but other neuromodulation techniques are also influential in psychiatric treatments. It was a good presentation. Thank you. Dr. Kevser Nursaçan, over to you. Hi everyone, I'm a resident at Marmara University Pediatric Psychiatry Department. At Marmara University at AD, psychiatric complaints were seen and the clinical features of the cases applied repeatedly were examined in our study. Actually, the pediatric emergency services are key points for the mental health care. When you see repeated visits, you need to evaluate the effectiveness of the ED services, especially for the repeated visits. The underlying reasons for the repeated visits should be evaluated, and there may be some question marks regarding this. When we look at the literature regarding the repeated visits, sometimes we say the sex differences among the females. Damaging oneself, self-harming behaviors are more prominent, while among the males, violence and aggression are seen. Another finding is that psychiatric comorbidities, substance use, and psychotic disorders are also associated with the repeated emergency visits. When we look at the literature again, especially for women, repeated visits are more frequent for the age group of 14 to 17, and a history of psychiatric hospitalization is also a risk factor. Again, the diagnosis of depression is also a significant risk for increasing the repeated visits among females, and this study aims to evaluate the clinical characteristics of the adolescents who repeatedly visited the emergency of Marmara University. Our study was a retrospective analysis of adolescents who visited Marmara University Pediatric Psychiatry 3 or more times between 2022 to 2024. And we retrieved the data from the computer system database. The variables were clinical diagnosis, suicidal attempts, their ages, and the Children's Global Assessment Scale was used to evaluate the psychological functioning of the patients. And as a total, the study sample consisted of 50 patients. 32 were females, 18 were males. Median age was 14 to 15, respectively. And in total, there were 1,355 patients who visited the ED, and highest number of visits was 19 for these patients. And for the education, half of the patients were not continuing school, especially it was more among the males. The complaints started 19 months ago for the females, 25 months ago for the males, and the psychiatric follow-up was 13 for the females and again 13 for the males. The CGAS scores were quite close to each other between the males and females. For the diagnosis, more than half had mood disorders, 38 had ADHD, and 24% had anxiety disorders. 59 of the girls and 55 of the boys had comorbidities. For the girls, depression, ADHD, and anxiety were commonly seen. For the males, ADHD, depression, and conduct disorder were seen. Suicidal attempts was significantly higher in girls. 53% had suicidal attempts compared to the males. It was higher. For the psychiatric interventions, 86% of them used atypical antipsychotics, and more than half were using SSRIs. And what was striking that at ED, short-acting injection use was higher for the males compared to the females. And in conclusion, in our study, the girls were the majority for the repeated visits, and suicidal attempts were higher among the males, and short-acting injection use was higher among the males, and agitation, conduct, behavior were more frequently seen among the males, and again, ADHD and conduct behavior were most seen among the males, and depression was more common among the females. And another finding was the education. The males were more prone to discontinue their education. There may be a double-sided interaction, maybe aggression and violence could be the cause for their discontinuation for education, which further increased their conduct disorders. And of course, our study was retrospective. Therefore, there were some limitations, and there was no control group, and it was a single-center study. And in conclusion, it's important to know the risk group beforehand, and early detection is very important. And the interventions must be gender sensitive, and also a holistic approach is necessary, because when the patients come to the ED, the counseling services, social services, and family must be involved in the process, and they should be integrated into the polyclinic system in a proper manner. Thank you. Thank you very much. Any questions or contributions? A majority of the presentations were on pediatric psychiatry, generally ED applications, admission applications and indications are striking at the clinic. Therefore, we focus on this. Thank you very much.
Dr. Ecren.
So Dr. Ecren will be making the presentation, but however, she's not here with us here right now, and I will skip now. And Dr. Zeynep İrem and Dr. Eslem Öztürkgül. So I'm coming from the Süleyman Yalçın City Hospital, and unfortunately our ward was closed, and this was done before it was closed. And I will be talking about socio-demographic features and the diagnosis distribution of the children and adolescents that have applied to our ward. And this is a comprehensive evaluation would provide diagnosis, treatment, and crisis management, but there are some problems that would happen because of stigmatization and also the departing from the family. And of course, it's important to identify the high-risk patients, and our objective is to identify the distribution of the patients in terms of socio-demographic features, and of course, it is to estimate and foresee the patients, and it's a retrospective study, and it was carried out between February 2022 and October 2023. And this was carried out in a ward with 10 beds. And in terms of we use the scales as the measurements for case sets, PLT, and then statistics were also used for this. And in 250 patients, the median age was 15.86, and then the hospitalization was from the emergency, and also 26% were in the ward because electively, and the hospitalization was about, in the cases, 94.8% had the psychiatric story, and also 77.6% had a psychotropic treatment, and also 22.8% had a psychiatric in hospitalization before, and 66% had the suicidal had in self-harm intervention, and also 7.6% had suicidal interventions, and also 84.8% had a psychiatric disorder when they were hospitalized. And also the Axis 1 diagnosis, it's about the common decision made by the council as for the patients during the discharge, and 64.8% was about the major depression, and 17.2% was the attention deficit, ADHD, and 52.4% of them had then personality disorders, and also in 42.8% had then features that was compliant with the B cluster, and also the 31% were smoking, and 7% had alcohol drinks, and then the substance usage was 2.4, and in 27.6% had the CGS. There was a functional disorder, and also in terms of the clinical global follow-up in terms of the severity, it was found out to be 12.8% out of 5 from these, and the patients in 19.6% had the story regarding the exploitation. And during the hospitalization, 90.40% had the treatment with drugs, and 80% was about the atypical antipsychotics, and then 64.4% was treated with SSRIs, and 10.8% had the regulatories for the mood disorders, and the ADHD had the treatment with drugs by 6.4%. And when we look into the patients that were hospitalized, 80% had the education level at the primary school first degree, first year, and then 76% of them didn't have repetition of the classes. And the indicators for the duration of the hospitalization, panic disorders as well as psychiatric comorbidities were increased in terms of the hospitalization, and also in terms of the personality clusters. This was found to be significant. And also, most of the patients had the borderline disorder problems, and also in a study that was carried out in the adolescent psychiatry ward, the community was looked in these patients, and it was found that the internalizing and externalizing psychiatric disorders were higher. And also the internalizing disorder, which was found by MDB, was rather about anxiety, and with an anxiety disorder, this was accompanied with many others. In the MDB and the HDHD, we see that they have the impulsivity nature, and in terms of the hospitalization, 65.6% had the self-harm interventions and then intentions, and 94.4% was prescribed at least one psychiatric psychotropic was prescribed, and we see that it is one of the most common treatment. And in the children and the adolescent patients, it is about the drug usage. And in these patients, the psychotic usage is quite high. The antipsychotic is so frequently used. It's because of the comorbidities that is high. It's about the mental disorders, and also the acute crisis management is to be strengthened with the treatment. In terms of the treatment, in our study, the atypical antipsychotic compared to the typical antipsychotics, it was preferred more. And we say that it is because that it is tolerated more and better, and it has got less side effects. And also, just additional to the psychosis, it also has been found to be effective in terms of the management of the mood disorders. And when we see that the ADAs compared to the SSRIs, we see that SSRI is more tolerated more better. And then it is also about the specification of the drugs. And we see that the COVID-19 pandemic is also related with the symptom onsets in the patients by 15.6%. And also in the compilation that the adolescents and children had more psychological problems due to COVID-19. In the long term, we see that there's a need for the long-term studies with multicentral studies, and also in the hospitals, we see that the patients were diagnosed with MDB, and also the complex comorbidities where the children have the tendency to harm themselves. We see that there is a common psychopharmacological treatment for them, and the psychiatric treatments should be detailed, and also the supportive treatment should be formed as an alternative. So in our study, we see that the diagnosis distribution is rather different. We see that anxiety and trauma-related diagnoses have been already identified. And we see that the difference for the hospitalization is indicated related to the mood disorders accompanied with the anxiety disorders. And also in the child emergency department, there's a frequency for the application, and this can be affected by the children's and adolescents' mood disorders, and the support should be provided for this department, and the detailed information to be provided for this field would certainly support and contribute to this studies ongoing. Thank you. Thank you very much. So it's really sorry and sad that we have already lost another department in this respect. Any question? Is there anyone who is not psychiatrist among us? So there's adults and psychiatry among us. And clinics and also the services and wards, they are all related with the clinic, so it's good in this respect. Dr. Mustafa Tolga Tunagür will be with us right now. Distinguished participants, and we know that the HD is characterized with the impulsivity and hyperactivity, and we see that it impacts the social relations and as well as the overall welfare and with well-being. And in the attention deficit and hyperactivity disorder, we see that these executive functions may worsen the conditions of these children. So we thought that this works to be studied further. And also the sleep is really important in terms of the executive functions, and especially in the patients or the children for sleep. Or we see that the ADHD patients, there are many sleep disorders regarding the falling asleep, and then there are it distorts the cognition, and also it distorts the performation, and this is complex relation which needs to be studied. And also the objectives here that the patients that were diagnosed with ADHD, it carried out a study on the executive functions, and we see that there's a comparison of the sleep problems and the ones who do not have the sleep problems, and the children with sleep problems when compared with the non-sleep disorders, we see that they would have better executive functions. And in our study, we use the SADS-5T survey questionnaire, and then accordingly we named it to tour guide 4. It's also a scale that screened the ADHD symptoms, and also the patients, the parents filled out this form, and the cutoff was identified as the 41, and also 42 and the above were identified to not to have any sleep disorders, but the others had. And also we have this scale which is called, to be brief, and it's about the functional executive function behavioral evaluation inventory, and the high scores shows that it is about the worse executive functions. There are 8 low sub-scores, and there is also 3 index scores, and it is the scale that is consisted of 3 to 16. And Sakarya Research and Training Hospital, we all took the patients, the boys actually, and with this, between the girls and boys, especially during the childhood, we know that they have the executive functions differ from each other. And also in some studies in ADHD, we see that there's a problem depending on the gender. So for that reason, just to exclude this factor, we only took the boys, and then we screened them apart in terms of the mental condition, and also the tour guide, the attention scale was taken into consideration. The ones with 42 and above, this was mentioned to be the case group with the sleeping problems, and the ones with lower than 42 points and lower, they're considered to be the control group. And ADHD boys taken into the study, about 35 of them, and we wanted them to be between the ages of 7 to 12 age, as the median age was 9, and their attention deficit is 18, and then their hyperactivity was found to be about 18.3, and then in the 42 cases, they had the problems of sleeping, and the ones who had 41 and less, it is determined to be the control group. And when we look into the table, just briefly, the changing, and then emotional control, shift, inhibition, initiation, working memory, planning, organization of the materials. So we see that all these sub-scores, the case group with the sleeping problems found to be significant and high. So these are the children with high scores, the sub-scores as well as the index scores and as well as the total score found to be higher and significant. So in short, as a result, the children with the sleeping problems compared to the control group, we see that the brief total scores, brief sub-scores as well as brief index scores are rather high. It shows that the executive functions are rather more problematic. So as a discussion, we see that the executive functions, we see that it shows the critical role of the sleep, and in the sleep disorders in ADHD patients or children, it comes out to be worsening the condition or the output. And we see that the sleep problem certainly affects and impacts the metacognitive skills, and also the inhibition, emotional control, planning, organization, and also working memory. These all would be impacted with the worse outcomes related to the sleep problems. And we see that the executive functions are rather referred to prefrontal cortex, and we see that the bad sleep would certainly impact the nerve organization, and optimum treatments would be required for the synaptic performance, which would, of course, was previously inhibited, were weakened, and also the insufficient sleep would certainly impact this, and also these sleep disorders should be tackled in the ADHD patients, and the compliant and appropriate pharmacology, and also the sleep hygiene would help. For example, the routine would be formed by the parents, and also the parents would be trained to provide the good sleep for their children. As a result, we can say that in the ADHD, in the executive functions, the sleep has a critical role, and there is an intervention, a comprehensive intervention is required in order to improve the patients. And thank you very much. So thank you very much, Mr. Mustafa. So in the age where we now, and the sleep, the importance of sleep has been studied, and it is one of the most common pathology in the children's clinics. And this related to this study as well as this presentation, have you got any questions or contributions? I just would like to ask a question as a confusing or a mixing factor. So in this socio-demographic form, the screen usage, and you ask whether when the screen was. So in your analysis, you know that the screen exposure could certainly distort and harm the executive functions here. So in our analysis, we included this. There were two questions. It's about the usage or the exposure to the screen, and also at night, whether there is an exposure to the screen or not before going to sleep. And as I mentioned before, the socio-demographic variants, they were added to the analysis with 8 parameters, and they didn't change the results. But even though we do not add them, these results would be the same. So you say that these are free of the effect of the screen. So the executive functions are completely affected, whether this screen exposure is available or not. Any question? If there is any question, thank you very much to all of you who have participated. And Elif Merve Kurt also would have a presentation. So actually, I would be making the presentation instead of her. So who is with us here with the team? It's not in this list, indeed. So please, do you think that, are you sure that you're in this hall? There was a
Sağlık nedeniyle hocam.
Because of a health problem, she couldn't make her presentation. I would like to mention about the data about retrospective analysis of bipolar disorder. This is a chronic mood disorder, and it affects the life quality of the person, and it makes a huge burden on the health system, and it, despite the pharmacological important changes, it causes emergency service visits and long-term patient lying in the hospital. So there occurred the need for the treatment for these patients. So I would like to talk about these issues as LIA. This is another option, prospective option for executing the bipolar disorder, and giving the advantage of administrating as permanent drugs for these patients. It weaks the repetition of these disorders. While we're talking about when we talk about the
Hastane yatışları, acil servis ziyaretleri, hastane yatış...
we have analyzed the differences in the patients' situations during the layings of the patients in the hospitals. We have assumed that it weakens these issues. And during October 2023 and September 2024, for the patients with LAI, we have analyzed the situation. When there were patients that were held out of the analysis during this, and there was some emergency service applications, and we have made some comparisons regarding all of these patients, and we can see the socio-demographic data regarding all of these patients in this table, and the doses and the periods of this patient lyings in the hospital. And we have reached out to 45 facts here. Their average life term is 39, and average follow-up period is approximately 15 years, and they have been using the amount of injection for all of these patients. When we look at this table, we can see that before the patients lies in the hospitals, the health parameter was different. We have made a comparison between these data, and there we have observed a significant change in this table of the patients, and we have defined the patients lying in the hospital, and we have hospitalization was really decreased in this period. And we have observed a really good improvement in the hospitalization of these patients. And on the other hand, recent studies shows us that there's a decrease in the clinical data in this regard. So they are compliant with these issues. And on the other hand, with the next studies, we have observed that there have been a really good change in this sense. And in this sense, we can say that we can improve the health health service quality in this sense. So on the other hand, and this is also something about the individual approach for the treatment of the patients. Thank you very much for your attention. Thank you very much, Dr. Mustafa, for your presentation. If you have any questions, please don't hesitate to ask them, because he has mentioned about some effective and frequently used options regarding the bipolar disorder. Thank you very much for joining.